The following presentation is regarding peritonitis, a complication of elimination GI for Concepts 2 nursing students. For peritonitis, we have primary peritonitis and secondary peritonitis. Primary peritonitis is when there's an acute bacterial infection that's not specifically associated with a perforated organ or a perforated peritoneal lining. It can be associated with an infection by the same organism elsewhere in the body. Example of this may be tuberculosis, alcoholic cirrhosis, and ascites. Patients that have infection within their ascites can also get infection within their peritoneal cavity. Primary peritonitis is not common. The more common type that we see is secondary peritonitis, which is from an invasion or a perforation, a rupture of an organ, a stab wound, pancreatic enzyme spilling into the peritoneal cavity, an ulcer, a stomach ulcer ripping open and spilling stomach contents into the cavity, a common bile duct ripping open, a biliary tree ripping open. Any type of organ that rips or perforates within the peritoneal cavity can cause secondary peritonitis. Clinical manifestations or assessment factors related to peritonitis. We have abdominal pain, rebound tenderness. So rebound tenderness is when you press and you let go. They say ow. A rigid board-like abdomen. So the rigid board-like abdomen comes when the peritonitis has moved from a localized to diffuse area. A distended abdomen, which is usually indicative of air being trapped in the abdomen, which would sound like tympany when it's percussed. Nausea and vomiting, just diminished bowel sounds, inability to pass flatus or feces, a high fever, hiccups. What will happen is the peritoneal cavity will become extended and will press up on the diaphragm, causing irritation of the phrenic nerve, which will lead to hiccups. And that those same idea of pushing up on the diaphragm will also cause decreased lung expansion, which can possibly cause respiratory compromise in your patient. Diagnostic testing. First thing we want to look at is the CBC to identify if they now have a bloodborne or serum infection. So looking at WBCs and neutrophils, Chem7 or BMP, which is your basic metabolic panel. We're looking at fluid and electrolyte balances. We're looking at ideas of dehydration related to nausea and vomiting, and ideas of hypokalemia related to nausea and vomiting. Blood cultures will tell us if the infection is now systemic. ABGs, if your patient has hiccups and is starting to have respiratory compromise, if they have an increase in their respiratory rate and a decrease in their SATs. Abdominal x-rays and CT scans will help diagnose a perforated organ or a large area of purulent fluid, such as an abscess. And then a peritoneal lavage, which is what the picture is of on the right-hand side. Peritoneal lavage is diagnostic, but it's also treatment. What happens is we take the patient to interventional radiology, or in some hospitals, an operating room, and we remove a small amount of fluid from the peritoneal cavity, and we test it and we see what bacteria is growing there. They will try and remove as much of the purulent matter as possible, and then they will lavage or wash the inside of the abdomen with an antibiotic solution. Patients that have peritoneal lavage need to be monitored closely for signs and symptoms of infection as well as bleeding. Pre-peritoneal lavage, patients should be withheld from all blood thinners such as aspirin, Coumadin, Lovenox, and heparin. Nursing process. Think back of what are the clinical manifestations of peritonitis. Think about what are the patient's vital signs if they have a fever. So if a patient has a fever, they're going to be tachycardic and hypotensive. If they have pain, they may be tachycardic and hypertensive. Have they been vomiting? Because not all peritonitis patients vomit. So think about looking at the patient and identify if the patient has a fever, if they're in pain, or if they're vomiting when you're looking at their vital signs. The plan, short-term nursing plans or goals of peritonitis: comfort, decrease pain, decrease infection, decrease nausea, vomiting, decrease constipation, and maintain hemodynamics. If you're looking at this, I want you to think about what is the most important. What is the priority of all of these? A, B, C, P, as we discussed in class. So interventions, maintain comfort and decrease pain. You're going to do a thorough pain assessment. You may give pain medications. Please remember to look at blood pressure and heart rate in relation to what pain medication you would actually give this patient. Position of comfort is usually supine with the knees flexed to decrease the angle of the pulling on the abdomen. Decrease infection, we would monitor for any changes in the vital signs and in the labs, and we would potentially be giving IV antibiotics. Decrease in nausea and vomiting, we're going to want to monitor the GI function, maybe give them antiemetics, potentially an NG tube. And decrease constipation, we're going to monitor for bowel movements. However, the use of laxatives and stool softeners are actually contraindicated in your patients with peritonitis because we don't want localized pockets to be spread and the peritonitis to be diffused throughout. Maintaining hemodynamics, we want to look at the fluid and electrolyte balance, and they may need this balance with a large amount of IV fluids. And when you're studying for this material, look at the interventions that we just did and write an evaluation statement. How would you know that those interventions work? Complications of peritonitis. One of the major complications we have is something called third spacing or the fluid shift. They get a localized fluid shift in their abdomen during periods of peritonitis. So if my fluid is now outside my vascular space, I would expect my patient to be hypotensive and tachycardic. An ileus or an obstruction can also happen from the amount of pressure within the abdominal cavity and purulent material and the infectious process pressing on the intestines may cause a neurologic obstruction. The peritoneal cavity is very vascular. There's lots of blood that flows through the peritoneal cavity. So it's very easy for your patient to get bacteremia or septicemia from peritonitis. So it will go from being a localized infection to being a systemic infection. Potentially they could also have respiratory distress from the pressure pushing up on the diaphragm and decreasing pulmonary function. Potential surgical management for peritonitis, they could have exploratory laparotomy. It's called an X-lap. That's if we don't know where the infection is coming from or if we have a perforated organ, such as an appendix. They often have to have an appendectomy. Patients can also need a colon resection. If we have patients that have Crohn's disease and they end up having a fistula and an abscess, this can then turn into peritonitis, so they would have to have part of their colon resected. They could potentially have a drain inserted. You see the drain on the right-hand side here. When you're looking at that, I want you to think about what's wrong with that drain, because that drain doesn't look right. There is something that's incorrect about that Jackson Pratt or that JP drain. And then potential flushes with antibiotic solution, and that's what they would do with a peritoneal lavage. Prevention for peritonitis. Peritonitis can be avoided. You want to look at patients that have risk factors. So for primary peritonitis, we want to look at patients that have tuberculosis and patients that have ascites and making sure that they're taking their medications for their tuberculosis, and perhaps they're having their fluid tapped for ascites. This is why we tap fluid for ascites, so it doesn't cause peritonitis. Past medical history, we want to identify if they have a history of Crohn's disease or if they have a history of an intestinal obstruction in the past. Nursing interventions to prevent peritonitis, a very good assessment. Knowing bowel sounds, specifically bowel sounds per quadrant, specifically patients' soft palpation to identify if patients have rebound tenderness. Knowing your patient's abdominal assessment well, knowing their percussion and the tones of their abdomen as well. Patients that come in with GI elimination problems should have inspection, auscultation, percussion, and palpation for every assessment. Vital sign frequency, should look at vital signs, look at trends in vital signs, identify if your patient's becoming hypotensive and tachycardic, which show signs of infection. labs monitoring not just their white count but their neutrophil count as well, and maybe even a C-reactive protein or a cytokinin to identify if there's any infectious process going on in the patient. And then medications. Obviously, antibiotics are what's going to prevent peritonitis, so patients having antibiotics on the correct schedule and having antibiotics as ordered. Thank you.